Hey, everybody, it's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni and Ray Pace and Dr. John Hill with us yet again. Special 5-part series for all of 24. So what we're doing is we're doing a ongoing sub-series on EMS airway management. All right, so stay tuned for this installment of EMS Airways. All right, next section, we're rolling into all the surgical airway stuff. So we need to talk about needle cricothyrotomy. We need to talk about cricothyrotomy kits and surgical crics. And yeah, I mean, we're kind of in a last resort situation here, right? So we've tried everything top down, right? Mm-hmm. So we've tried either a standard DL or VL intubation, or if we're if we're a basic shop, we've tried a King or an LMA or some other supraglottic. We're in a unable to intubate or unable to ventilate situation, or there's some sort of massive trauma or something to the face. We can't get in the airway.
You've tried your bougie.
Yeah, we've
tried
the tricks, right?
Pressure.
We've optimized everything.
Correct.
Yep.
And you're unable to ventilate.
Yes.
You're unable to ventilate.
Unable to ventilate from the top.
Yeah. So we just need to roll into some sort of neck access, right? And the way our protocol's structured, that kind of varies with your training level, what your medical director prefers. But basically, we've got those three options available to us. Some shops may have all three options available: a needle cric, a quick trach, or some sort of cricothyrotomy kit. In this area, the quick trach 1, the quick trach 2. Seems to be the most prevalent. There's a few shops around here that have the control cric and a few other variants, and then there's 4 or 5 different kitted cricothyrotomy systems out there. And I think, without diving onto every one, we'll talk about the one that's most common in this area. But whatever packaged cric kit you have, ultimately you have to have hands-on training and experience
Absolutely.
with that. That's not something like, oh yeah, I looked at it in the package once, I can figure it out.
This is not something you watch a video on YouTube on, and then you're
Right.
like, okay, you know what? It says if trained in the protocol, so now I'm trained.
I'm trained
That's
now.
not.
Well, this is a rare procedure, right? This is a
Exceedingly
once-in-a-lifetime
Correct.
typical. Most people don't even get to do this procedure in their lifetime. If
Right.
you're doing it multiple times, you're working in an extreme situation.
Extreme. Yeah.
Or, dare I say, you're just bad at airway management. So,
There's also that, right? It can't be a crutch.
correct.
That's,
it shouldn't
yeah,
be a
right,
crutch, right? If you're going to have a crutch, your crutch should be bougie. Bougie should be your crutch.
Yeah, or some other tool.
Visual
Or
video-assisted laryngoscopy. I mean, those tools are so great that we've talked about AirTrack and how that's easy. Bougies are great tools to have. Practice and learn your bougie. I mean, you should know how to do cricothyrotomy, but definitely this crics, surgical airways, are your airway of last resort. Obviously, any airway you get's a good airway from up top, but again, this is last resort, and for UH, you have to have med director approval and training, which we'll go into a little bit more.
And not medical director approval before you do it, right?
Correct.
This isn't.
Yep.
We don't have to call for this.
No.
Because it's absolutely ludicrous if you need to pull the trigger on some sort of neck access or somebody's airway. That's not the time to be like, hey, mother, may I? So all this training it all needs to precede the event, right? This isn't. I should be calling and hey, can we do a thing?
No.
And all of that is, mostly in the adult population. We have more stringent in this area, more stringent controls on the pediatric population, and we limit that just to needle cricothyrotomy, which we're going to just talk about here in just a second. But really, when we're talking about those 3 different options and that prior medical director training approval, we're talking about, in the adult population, right?
Very, very low frequency, though. I mean, out of all of these squads in University Hospital's protocol, in the last 12 months even, how many of these have been done? Maybe one?
I had one.
Attempt?
I had
I
one
mean,
just recently.
So out of all the squads...
Yeah, it's one annual.
Yeah.
We typically do one in my emergency department a year.
And then if you
Most
look at the amount of
are one a year.
intubation attempts, it's far more. I mean, so this is, again, not something... I mean, in class, we teach it for medics.
Right.
That doesn't also warrant you to do this in the field. You still need your medical director to do the training and approval to do it. So what you get in medic class isn't even that. But I mean, we teach it in class, and that's about the only time somebody will ever do this.
Well, I mean, to that point, how many of you guys have done a surgical crike?
Never
I've
on
come
a live,
close.
never on a live person, right?
Well, in training, or they're already dead?
Yeah, it was on a.
I've done a cadaver. Yeah.
Okay.
Yeah, same,
But yours
same
was
here.
a
Cadaver
training.
The close, and actually, I was going to share that story here momentarily about what got me on a mental path to better understanding cricothyrotomy, because I had the case where I was so close to needing to do it, right? And that was, I probably talked about it with you guys offline or maybe on here before, but it was a tracheal cancer patient, and we walked in, and she's doing, CO2 narcosis, CO2 narcosis, head bob, she's sleepy, she's stridorous, we just hear her when we're walking in the door, and we're like, there's no fix here, right? There's very little I'm going to do. We identified structures. We had her prepped. I had her marked with my Sharpie. I was ready. I had the quick trach open. It was all out. We didn't have protocol at the time for. I mean, I'm going back almost 20 years. We didn't have protocol at the time for
Before COVID, BC.
15 years BC. Quite some, and I called the. I called medical control and got permission to nebulize epinephrine because we didn't have racemic epi at the time for upper airway stuff. And I said, "Look, here's what's going to happen. I'm going to walk in there with a quick trach in this patient's neck, or this works." And it bought her enough time. She ultimately did get advanced airway procedure. We got the Strider mostly improved. Stats came up. Mental status started to improve a little bit. They BiPAP'd her in the ER, and this was like early in the use of BiPAP at 15, 20 years ago, right? And within about a half hour, she was in the OR and got a full-on tracheostomy. So
that's probably the best course.
And that was the best course, right, for her, right? So we bought her just enough time, but it was, in my mind, I was like, I got her neck prepped, I got her, and half of me is like, holy shit, I'm going to do this. And the other half of me is like, oh my God, I'm going to do this, right? Mm-hmm. Am I going to be able to get in the right spot, right? And that set me on a crash course, which had me then, seek out cadaver labs, and I did a bunch of research and watched a bunch of stuff and read a bunch of stuff on cricothyrotomies. And I guess the resounding thing that I had to get to mentally was, and I've got my 3D printed airway here, but just for easy demonstration, is once I came to the realization that you've got this giant block of cartilage in your neck, and the only soft spot in that whole
is where you need to be.
Is where you need to be, right? I needed that simplicity in my mind, and to understand, like, even if I'm having difficulty palpating, if I take a catheter or a needle or something, and I find that only spot that is not cartilaginous,
you're there.
That's my spot, right?
Yep.
That's my spot.
Wouldn't want to go east or west with it.
But correct.
Anything in midline.
Anything midline, right? Now, most people, my observation has been that even on people with larger necks, you can at least appreciate the thyroid cartilage, right?
Yeah.
And I know as long as I'm south of the thyroid cartilage, right, and midline, well, I may have to move around or poke a little bit, but I can find that soft spot in there. Once I got that, I understood that anatomy, and I got that wrapped around my brain. I'm like, okay, I could probably get this done, right? And, my experience on the cadaver was with a quick trach, and I'll share a little more about that later, because there's some nuance to that I think people I know people don't understand. They look at it and are like, oh, it's just an over-the-needle catheter, like an IV catheter, and there's some differences when you actually try to put it in tissue, rather than a mannequin. And I guess my warning here, since I've got this in my hand and we're talking about it, is, this is a trainer that I 3D printed, and it's got this nice gigantic hole here, right? Convenient for training. But, even if you feel your own cricothyroid membrane, I mean, your target is really,
it's very small.
It's only like that, right?
When I teach this, I have people palpate their own.
Right.
And a lot of people are like, I can't find mine. I help them find mine. Like, it's the tip of your finger. That's as big as it's not a huge space you're aiming for.
And when we get on to doing a blade surgical cricothyrotomy, you have to make space,
Yes.
right? You have to make space and get in there. And even the quick trach, the things I want to talk about, you're making space with that quick trach.
You're moving a lot of anatomy.
So this almost, I don't want to say it sets you up for failure, but it's necessary for the training piece of this to get. Because we'll put some layers of tape and stuff like that to simulate skin, and then we'll cut through this, and
Oh, but not to
do the
mention, I mean,
techniques.
I know where you're going with that, but even the vasculature on somebody who's not dead, you have a lot of bleeding there.
You'll have blood, right?
Yeah.
It will bleed, and you have to be okay with that,
Yep.
right?
Yeah.
It shouldn't be pulsatile.
Right.
Shouldn't be.
Again,
You've
midline.
Yes, you've gone too lateral then, but understand that as you go down farther south, you've got your thyroid, very vascular structure, and then you have an innominate vein that cuts across from left to right. That if you go down far enough and sever, it's going to bleed a lot more than just the skin that's going to bleed.
Right.
But the skin, I mean, it's almost obviously part of your face. It's kind of obvious, but your face is very vascular.
Very vascular. Yep.
That's why we turn red when we get embarrassed. It's very vascularized, but so is your neck's pretty vascularized too. And even dead patients, we're doing CPR, they bleed a lot when you're doing crikes.
The other kind of point that with that blood and bleeding, and I've had some people like worry like, oh, I'm going to get a bunch of blood in the lungs. They're going to bleed into their lungs. And the funny part is the body does okay with blood in the lungs, right? It's far superior. Not that it's great, right? But the body knows what to do with blood in the lungs. Obviously,
Not
it
so
should
much
be
in the GI
pouring in,
tract, yeah,
right? But if you get vomitus in there, if you get water in there, that's real badness. If you watch some blood get sucked in, that is. The body will know what to do with it. It'll reabsorb. It'll be generally
sort
okay.
Of that, going through the neck, you're going to have blood in the lungs.
Correct.
So
You're going to get
exactly
blood.
right. I mean,
It's
but
just not going to be a large amount. Yeah, you're going to.
we hope.
Yes, it should be only a little amount in theory. A lot of your blood is still, going to be exterior essentially, but I don't think that there's going to be a substantial amount that would enter the lungs. To your point, like aspiration and stuff like that.
Yeah, but I know people have been concerned about that, and I just want to make sure that was said. It's just like, okay, if you got some blood,
Again, though,
if
I
some
think we
blood
need
goes
to-
down the hole,
we need to
it's
take a
not
step
the end of the
back
world.
and understand that if we're doing this procedure, it is last ditch. And so if you're worried about blood in the lungs at that point, that's my last worry.
Yeah,
Because
they're either-
you need to get an airway.
They're either
going to
be dead and
Correct.
they're apneic and can't breathe and they've asphyxiated, or they're peri-arrest.
Yeah.
Right.
And that all that probably means is their heart's still beating at 120 times a minute and they just can't ventilate.